Very good morning.
Good morning.
I was little worried because the case this morning had very bad hemodynamics. We have just been able to stabilize her. So I'm doing this case from Sahyadri Hospitals, Pune, which is a growing group of hospitals in the city of Pune. I'm Dr. Suhas Hardas. On my right is Dr. Priya Palankar, my colleague, a consultant cardiologist. Behind are Sister Eliama, Shantanu, Satish, Amol, all cardiologists. We have a case of 93-year-old lady who approximately 7 days back presented with LAD syndrome, lot of angina, and had a LV ejection fraction of approximately 28 to 30%. She had on echo significant hypokinesia involving the LAD-related myocardium, but preserved thickness and some enzyme leak. Taking into consideration that she was 93 with a history of diabetes of last 18 to 20 years, hypertension for the last 30 years, we decided to manage her medically and thought if she settles down on medications, it would be a good thing for everyone. But unfortunately, having managed her with all possible, best possible medications for 3 to 4 days, she continued to worsen. Her LV ejection fraction dropped down to 20%, and therefore we decided to intervene. We had an angiogram yesterday. I will play the angiogram in a while, but I would want somebody to quickly show the echocardiography, please. This echocardiogram was done this morning, which shows that the LAD-related myocardium is fairly viable, full thickness, hypocontractile, and the LV ejection fraction, once again, after having put her on dopamine, dobutamine, has slightly improved. The ECG is slightly better as compared to what it was 3 days back and 5 days back. There is a lot of groin tortuosity, so we are using a long sheet and we have decided to do this case through the femoral route.
Yeah, show to fluoro, please. Go to fluoro now. Echo is enough. We're still seeing the echo picture.
Oh, really? Okay, can we go to fluoro, please?
Yeah, we can't see it. Don't feel bad about femoral. This is 3 for 3
your
femoral
left
cases in this session.
Volume thoda sa badha.
All right, we can see the guide going up.
So that's a long sheet. Guide going up, yes. Show the next one, please. We have parked a temporary wire in the IVC, not put into the RV. And since this session was going to be about dealing with calcium,
Wow.
These are the pictures in front of you.
That's pretty impressive.
That's not very impressive at my end, boss. We have a 93-year-old lady with a systolic blood pressure of 80 this morning. And we have slightly better hemodynamics right now. Lot of complication. And any thoughts about what should we do next?
So at least in our practice, this is one where we want to think like heart failure physicians in addition to the technical part of interventional cardiology. We would do right heart caths routinely in these patients, leave the right heart cath in during the entire procedure, whether it's done brachially or femorally, it's fine. And the rationale for it is not only to see where we're starting, then we can determine if we need to use hemodynamic support or not, but similarly, during the case, you can observe changes in the PA pressure before the patient starts coughing and going into pulmonary edema, et cetera. So it really allows us to better determine how best to treat the patient. Sometimes also, if you've already put the patient on dobutamine, I'm assuming you've diuresed her, et cetera, we stop the case and we do that for cases that have not already had that done. So we just think of it as
we have done that, and for
Please go on. Definitely, I think extremely important point is to go straight forward, to have a plan, and just go ahead, not to be too complex. You
Yep.
know, just focus your attention to the most important lesion, and try to catch this lesion.
Yeah, I
I'm
think
not sure IVUS is even here so necessary, because I remember I had some live case.
You'll get sick with the
during
IVUS.
the IVUS patient collapsed,
Yeah.
and was resuscitation.
I mean, so the target's going to be the LAD, obviously.
Exactly.
But the one thing also to be very
Yes.
cognizant of is in your desire to do this quickly and fast, if the diag shuts down, the patient's going to probably get very sick.
Absolutely.
So you have to maintain that patency of the vessel.
Absolutely. I agree, because the right coronary artery, we have not shown here
It's
because
occluded.
the angiogram was done yesterday.
Yeah.
And it is totally occluded. It's a non-dominant, totally occluded RCA.
You have
So this is a sole surviving vessel that we are going to be dealing with. And this is a quick run of the OCT that you can see. And I'm going to play the OCT. I would be very happy if you discuss the OCT findings. Can you play the OCT? Can you connect it to the OCT, please, there? The transmission team.
We're able to see the OCT. You can make, we can go ahead.
Yeah. You're able to see the OCT there?
Yeah, we can see
Yeah, we can.
OCT.
And
There
again,
is a significant calcification, and the calcification is almost 360 degrees at several places.
yep.
The longest length of a total calcific ring is approximately 7.5 millimeters at one point, which seems to be maximal around the area of the septal artery that you see on the screen. And the main luminal area there is approximately 1.1 millimeters. So we have an elderly lady with a long calcific LAD disease, which is the sole surviving vessel. Borderline hemodynamics slightly better now after we had that OCT run. She was ischemic. She dropped her pressure significantly. So we had to hurriedly do that OCT run.
So this is a challenge.
So what is the overall impression of the panel?
You
So
know,
what is the minimal diameter in this ring calcification? So, because this will be
Can
option
you show
to
the,
approach with rota.
Sure.
In our cath lab, option will be to use orbital.
Yeah, I would agree. So for us, this is, for me at least, if this favors orbital over rota for two reasons. One is because you can do everything with minimal profile and you can maintain flow, but also we tend to see less slow flow with it. The challenge is that for us, this would be a case where we would do on support. And the reason is because the blood pressure is marginal, the EF is terrible, and if you have to do atherectomy, you're likely going to get stunning on the only vessel that's supplying the whole heart. So we tend to be very judicious about the use of hemodynamic support, but for us, this would be a case where we would use it. So what is your, what are your...
Absolutely.
What's
What
your
we have
plan?
done for the time being with the limited resources that we have a femoral arterial puncture on the left side. So in case there is a need, we will probably put in an intra-aortic balloon pump. That's the best hemodynamic support that we can probably use here with the resources that we have.
No, and the balloon pump is better than nothing. There's no question about it. And so
Yeah. Sure.
for me, I think if you're getting the puncture already, then I probably would do it on a balloon pump rather than wait and see what happens because she has so little reserve. I don't know if anybody else feels that way.
I think there is no clear data, but experience on this level. And I think if you don't have impeller options, so IBP will be additionally probably helpful.
It's just the groin and the leg looks a bit tortuous, Suhas. So that's the only worry. Otherwise, I would have put it
Absolutely.
in.
An elderly lady with diseased aorta, you could see that the aorta was calcific, it was tortuous. So that's another concern about putting in an intra-aortic balloon pump. As somebody just suggested, I think an impeller would be ideal. But we know, Ajit, that with our resources that we have, it's pretty challenging to accomplish these things.
Yes, Suhas, we don't need to be apologetic
Yeah,
about
we
it.
totally understand.
Yeah.
So
we don't need to be
Do you
apologetic.
go now with impeller, with IBP pump ahead?
Yeah, just last week
Sure.
we
So,
have a propensity
what
match
do you
to
think
data.
we have?
We have a propensity match data last week in JAMA Internal Medicine that Impella is worse in terms of outcomes as compared to IBP, 900 patients.
Yeah, that's totally confounded, though. I mean, look, I'm the first to admit that the Impella data is not great either, but that paper is not worthy of, honestly, being the notoriety it got. The one thing I'll say, though, is there in the randomized trial that was done, balloon pump versus nothing, the primary endpoint, which was a composite endpoint, was negative. At 5 years, mortality was less with the balloon pump. But if you look at the three things that we care about in the cath lab, and that's CPR, ventilation, or need for vasopressor support, they all favored the use of the balloon pump up front. So my sense is if you don't have Impella, then it'd be worthwhile doing. But why don't you show us what you're going to do? Are you going to plan on doing atherectomy? I'd be very worried about doing atherectomy with no support in this case.
I'm keen to hear from the experts whether we should go ahead with IVL because the calcium is very deep, calcium is very long. And we do not have a luminal peeping calcium as much. So do you think we should be doing a rotatripsy or just the IVL here or rota alone will be sufficient? And if we have to do IVL, what is the suggestion of the panel about the sizing of?
I think you still have, so from my point of view, if you don't have hemodynamic support, you have to work very fast. You have to prepare the patient's center line, some drug option, you know, to be ready for some emergency situation. And I think you still could try to make a channel with 2.0 and C balloon to see how it's open. If opens well, you could still work here with OPN balloon then, because this will be the fastest way. And if this doesn't really work, then the only option I see in this situation will be to use at least 2, 3, 4 runs of shockwaves and to let sometimes between, you know, to recover the flow.
The problem with the compromised hemodynamics and trying to deliver the shockwave with a guide extension and all this stuff is she's going to get ischemic. So I think that trying to do balloon inflations first rapidly with the balloon up, the guide disengaged, come down, come in, come out, that's probably how I would tackle it if I didn't have support.
So use a non-compliant balloon and just hope that we are able to crack the calcium.
Well, first, right? First compliant, make your channel, then the non-compliant, and then see how it goes. But this is a tough case. It's 92 years old, and you really don't have a parachute, if you know what I mean.
Exactly. So go ahead with
meanwhile, in case you would want to go to the in case you want to go to the other lab, we will work on the case and come back to you after another 10-15 minutes. If that's okay, Srini?
Yeah, okay. We'll just take 5 minutes there and I'll come back to you then, okay? Can you switch to breech candy?
Great. Thank you.
Suhas, we are with you. Show us what you have done till now.
Okay. Srini, actually, I did not quite go by whatever the faculty told me. They wanted me to dilate it initially with a non-compliant balloon. What I thought after having done the OCT was that we should do IVL.
Okay.
But finally, I ended up rotablating this because I wanted to make sure that we will have a smooth passage of the hardware. So can you show the rota runs, please?
How did she tolerate the rota runs?
She did have hypotension after the second run, but we have a good anesthesiologist here who quickly pitched in, and we have hemodynamics once again back to normal. Show all the rota runs, please. Let's go through them quickly. Yeah, play this. Can you get the AP cranial here on your right panel?
So doing rota in this case is both high risk and high reward, because once you do it, if she tolerates it despite the stunning, then you've made your whole case much easier.
Right.
Yeah, absolutely. Next, please. Show the rota run. Yeah. Keep playing that one because that was the difficult one. Next, please. Next rota run. Yeah. So next, please. After this, we did the NC balloon dilatation of the entire segment with a 2.5 by 15 millimeter NC. Next. Next.
And these were very quick
And
inflations?
then over that balloon, we got the, yeah, they were very quick inflations. So you can imagine in the last 15 minutes that you have given us, we have done the rota. We have put in 2 stents, 2.75 by 48, overlapping with 3.5 by 18 millimeters. Next. 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 Yeah. Show the deployment of that one. Next. Show the post-denting shot that we have taken. This is what we have now.
That's great. And the diag stayed open too.
That looks pretty good. Diagonal is open too, that's right. Yeah, God has been very kind to us this morning. So, one AP cranial view, RAO cranial view. The last one. Okay. I think the machine is stuck for a last RAO cranial view. We are going to do a OCT after this. And if we have to optimize the result, we might do that.
Yeah, I don't know if to be honest with you, I
We
would
will have to switch the system.
keep giving dye because even
Optimize
though
it further.
creatinine's 0.8 and she's 92 with a really, really bad ventricle,
Exactly.
I wouldn't do another OCT.
Just
Okay.
post-dilatation will be enough in
Okay.
this case.
So you want us to do a OCT run with a normal saline and see how it looks?
You can. I don't think I would. I mean, the fact that you've been able to do this, just post-dilate it, and I think you're okay.
Okay.
I mean,
Okay. Great. Thank you.
yeah, this is
Great.
amazing, amazing,
Yeah,
great,
congratulations
great work.
to
Yeah.
you. I think it was really
I think
very
a great
good
demonstration of a complex case. You have done it well.
Yeah.
Congratulations. Thank you.
Really, really.
We need to break for
Thank you,
lunch.
Srini.
Thank
You
you.
want to see Kirti's last shot or no?
Thanks, Srini. Thanks, Ajit.
We have to take a break.
Okay. Connect to
I think the machine is stuck, so we may
Okay,
have
take
to,
your time
go
and
off.
you can work in peace. Huh? Thank you. Can you switch
Probably
to
if you come back after 3 minutes.
maybe we'll break for lunch. We'll come back and if possible. Okay. Thank you.
Thanks. Great job to your whole
No
team.
problems. Thank you.